Thank you, John and Leah. I appreciate the opportunity to speak today. There it is. My disclosures, there is one that may be relevant, and that is that I have hosted 3 courses in our lab to teach EndoFLIP, which I will be discussing. So I did get paid to run those courses. It's not a lot of money, but so the history of Bougie use. So, you know, the landmark paper was in 1986, Annals of Surgery. Tom de Meester basically showed that with the use of an increasing size of a Bougie during Nissen's fundoplication, there was less dysphagia post-op. And for the next decade, the thought around all of foregut surgery was we should be using a Bougie, and a large Bougie at that, when we perform a Nissen fundoplication. However, there were reports now that came out over the next 10 years that showed that there were increasing perforations during Bougie placement during the operating room. And so then you could see that this pendulum started swinging the other way. And that pendulum went to reports saying, should we really be using a Bougie or not? Was Dr. de Meester's paper really accurate or not? And that led to the paper, the randomized trial by Emma Patterson and Lee Swanstrom, with almost 200 patients that was published back in 2000 in Archives of Surgery, where they randomized those 171 patients to either Bougie or no Bougie. They followed them out for a year. The Bougie group all had 56 French Bougies placed. There were actually no perforations during the study. And they followed them out with dysphagia scores. And what they found was that the group that had the Bougie place had significantly less frequent and less severe dysphagia long-term, which they defined as a year out, compared to the group that did not have the Bougie. And so this was the first level 1 data, first really, good randomized data to show that, using a Bougie was better from a dysphagia standpoint. After that, however, as you can see here, there's been multiple single-center retrospective studies looking at the use of a Bougie and whether or not it's really needed or not. And all of these papers basically concluded that you really don't need a Bougie during Nissen fundoplication. People have acceptable dysphagia rates and acceptable post-dilation or post-surgery dilation rates. But again, these are single-center retrospective studies and going against the randomized data. But my question, and I have a feeling it's going to be a little bit controversial based on what I've been hearing today, but my question is, who cares? How many people in here that when you do a toupee fundoplication or a door, use a Bougie? Okay, okay, one, maybe, okay, one and I guess 1.5. Okay, so the majority of people don't use a Bougie during toupee fundoplication. So I guess the question is why, I've heard a lot about tailoring, our workup, helping us kind of decide should we do a Nissen or a toupee. But we have level 1 data here to show that we should always be doing a toupee. There are randomized trials like this one by Hackinson that have show that a toupee is just as good at reflux control. And if you look at dysphagia post-op, toupee has less dysphagia. So we have equal GERD control with less dysphagia. So who wants a Nissen if that's the case? And none of you use a Bougie when we do a toupee fundoplication, so why should we even be talking about Bougies? Well, I will say that all of you that didn't raise your hand, let me ask a question. Who has never seen dysphagia after a toupee fundoplication? Okay, no one's raising their hand there. So we still see dysphagia after toupee fundoplications. We see less, according to this randomized data, but we still see it occasionally because it's the crura likely that's too tight. When we get dysphagia after toupee fundoplication, we would conclude, as long as there's no recurrent hernia or other type of anatomical defect. So wouldn't it be nice if we had a smart Bougie that could tell us how tight we should close the crura? This is our experience since the randomized data came out, toupee versus Nissen. You can see here that even despite COVID there in 2020 or so, but we are almost exclusively toupee fundoplications right now. Now, I will caveat that by saying that what we had been doing and have been doing is using EndoFLIP in the operating room to assess the lower esophageal sphincter in the operating room. And if the lower esophageal sphincter after hiatal hernia reduction falls within a normal range, our thought was you don't need a Nissen fundoplication, that the majority of their symptoms will probably go away by just crural repair and a partial fundoplication, avoid all the gas bloat and the dysphagia. And when we did that protocol, what we found is we were doing a Nissen 5% of the time. That actually most people, when you tested their distensibility after hernia reduction, they had a normal distensibility 95% of the time, or most of the time, not 95%, a little bit lower. I'll get into it in a minute. But EndoFLIP is now here, and we've done almost 1,000 cases now. We've been using it since about 2012. And this is a balloon-based catheter. I think hopefully most people know about it now, but it emits constant low current, and the voltage change is then used to derive a cross-sectional area. Now you have the pressure that you're putting in that bag, and now you have a cross-sectional area. So when you have those two measurements, you actually have a distensibility index. And that's what we typically will use. So here's a typical EndoFLIP findings in the operating room. So on the very left, our protocol has been after hernia reduction, because in my opinion, especially if you're dealing with a paraesophageal hernia, whatever that definition is, but if you're dealing with a paraesophageal hernia, you can get a falsely low distensibility based on the kink, the anatomical deformity from the paraesophageal hernia itself. So putting the flip down before you've done any work on reducing the stomach, to me, is a meaningless number, because you could get a very low distensibility, but that's not truly the LES. So we actually dissect out the hernia and reduce it. And when we have that 2 to 3 centimeters of intra-abdominal esophagus, we actually then place the catheter and get our reading. And that's what you can see on the very left. And that's where we used to make that decision. Should we do a Toupet or Nissen? If the patient has normal motility preoperatively and is not old, so over 80, and has very high distensibility, over 9, we would do a Nissen fundoplication. If it was anything less than 9, then we would do a Toupet, with the idea being we shouldn't make the supraphysiologic valve in somebody that has normal distensibility already. And then you can see after crural repair, which I think right now is probably the most important measurement that we can get during a hiatal hernia repair. That's a typical kind of finding there, where you go from the picture on the left to the picture on the right. And what I will tell you is that typically with a 30 mil fill and insufflated abdomen, if we see a DI of 0.8 to 2, then I think that's the sweet spot for a crural repair. Anything less than 0.8, I think you're at risk for too tight of a crural closure and dysphagia post-op. I think anything over 2, we haven't proven it yet with our own data, but I worry a little bit about recurrences in the future, that you've left that hiatus too open. And then on the right, we also get a measurement at the very end, which again, typically doesn't change that much. If you use a Bougie and you do a Nissen fundoplication, you actually will see that distensibility go up, even though you think, well, it's going to be less now that I've done a fundoplication, but you actually won't see that most of the time. Oh, press the wrong button, sorry, yeah. So one of the things that we looked at is, does EndoFLIP help? Does it correlate with postoperative symptoms? And we published this a couple years ago. We basically looked back at about 200 patients, and we follow our patients lifelong, if they let us, if they respond. We ask them questions, we send them, quality of life scores, GERD scores, dysphagia scores. And what we found here is there is a sweet spot. So that green line is a sweet spot. So that's a distensibility that is not too low and not too high. The red line is a low distensibility, and those patients actually will report higher reflux symptom index scores. However, if their distensibility is too high, then they probably have ongoing reflux. And so again, you see that RSI score significantly higher than those patients that are in that sweet spot of 2 to 3.5. Dysphagia is not the only problem we all deal with. We deal with gas bloat as well. I would actually argue that dysphagia to me is less troubling than gas bloat. And the reason for that is I feel like there's something I might be able to do about dysphagia, but gas bloat, sometimes you kind of worry, like, what can I do about it? Gas X doesn't really work, but we give it to them anyway. So what we did find here is that, yeah, if you have a very low distensibility, if you're too tight, then the gas bloat scores actually go up. And so again, we wanted to shoot for that distensibility of over 2. Interestingly, dysphagia, we didn't find a difference, but that's probably because we didn't let any patient leave the operating room with a dysphagia score that was low. So again, as I mentioned earlier, if you have, a distensibility that was low. So if you have a distensibility of 0.5, those patients are possibly going to have bad dysphagia. And we didn't have really any patients. I don't think we had any patients with a distensibility of 0.5 that left the operating room. So we didn't show a good correlation there. So, sorry, I pressed it too much. But basically, in conclusion, I think that if you believe in Nissen, fundoplication, then the best data available is that you should use a Bougie, okay? I would suggest that you place it yourself. We actually implemented a policy in our hospital that the surgeon has to place Bougies, whether it's a sleeve gastrectomy or a fundoplication. And the reason we did that is because of some nightmares that have happened in our state, where anesthesia places a Bougie, perforates, patient has a terrible outcome, and you have anesthesiologists and surgeons fighting with each other. And I'm fortunate to be in an institution where we get along extremely well, and I didn't want that to happen. We were having an occasional perforation when anesthesia would put the Bougie down, both sleeves and fundoplications. We implemented the policy of a surgeon placing a Bougie about 4 years ago. We haven't had one perforation since. It's a pain, obviously. De-scrub, go out, place the Bougie, have to scrub back in, but I'll take that over a bad perforation and a bad outcome in a patient. So we're not using Bougies as much anymore for fundoplications because we're doing more toupees. But if you do a Nissen, I think you should use a Bougie based on the evidence. I could not find one article, and I looked pretty hard, that said that we should be using a Bougie during a partial fundoplication, like a toupee or a door. There isn't anything that's published out there that focuses on that question. So all of you seem to agree because most of us in here don't use a Bougie during a toupee, and I think that's okay. And then lastly, I think that EndoFLIP or intraoperative impedance planimetry is a very promising method for us to tailor, and I think probably the most important reading that we'll get is going to be that crural closure reading, making sure that we don't leave the operating room with too tight of a crura. Thank you guys very much. Happy to answer any questions.